Good afternoon. I'm Anuj Mehrotra. I'm the Dean of the George Washington University School of Business, and it is my pleasure to welcome you to this special episode in the summer series of George Talks Business. We are here today with the panel of health and public safety experts to learn more about COVID-19 in the context of colleges and universities planning to reopen their campuses in the fall. And of course, specifically to talk about how GW is preparing for return to campus. Please join me in welcoming Dr. Barbara Bass, Vice President for Health Affairs, Dean of the School of Medicine and Health Sciences at the George Washington University, and CEO of the GW Medical Faculty Associates. Next, I'm pleased to introduce Scott Bernotz, Vice President of Division of Safety and Facilities at GW. Also joining us today is Dr. Lynn Goldman, Dean of the Milken Institute School of Public Health and Professor of Environmental and Occupational Health. And finally, I'm pleased to introduce Dr. Pamela Jeffries, Dean of the George Washington University School of Nursing and Professor of Nursing. Now, knowing how busy all of you are, I really want to start by thanking you for taking the time to join us today. And we have a big audience based on the number of people who have RSVP'd. And I want to thank the audience as well for submitting a lot of questions, which I hope to get into in this time frame. But let me start with asking Dr. Bass to talk a little bit about what we know about COVID-19 virus at this point, perhaps certain key symptoms and the range of symptoms that people experience when they do experience symptoms, and how are symptoms different from just a flu or allergy symptoms? Tell us a little bit more. These are the kind of questions that we start with based on what the questions have been submitted.
Well, thank you, Anuj. It's great to be here. And I would say that if you'd asked me this question 5 months ago, I would have a pretty straight answer. It'd be, okay, you get a little pain in your chest, you get a little shortness of breath, you get flu-like symptoms, you feel lousy, you have fever. It's sort of a bad respiratory infection compounded with flu-like symptoms of myalgia, aches and pains and fevers. That was 5 months ago. We've learned a lot since then. And in fact, we've learned that the spectrum of presentation of COVID-19 infection is enormous. And in fact, we've also learned that probably close to half the people who actually are carrying the disease will have either minimal symptoms or even no symptoms. Those asymptomatic carriers actually are people we're worried about right now, as you can imagine, because if you're an asymptomatic carrier, we worry about whether you could be spreading this before you even know it. But these days, the portfolio of symptoms that people present with now include things like clotting disorders, stroke sometime, neurologic dysfunction. One of the classic one that's received a lot of interest in the press, of course, is anosmia. You lose your sense of smell, your sense of taste. That's a pretty characteristic and unusual symptom. So when that happens, that's a pretty good sign. But on balance, what I would say is the spectrum of this disorder is primarily that of a respiratory viral-like illness, fever, aches and pains, respiratory complaints of cough, and eventually shortness of breath. That's the classic finding. These others are less common. And we know that it's a disease that actually has about a 2-week spectrum of illness for most patients, often after infection for a few days before you start to develop symptoms. Then you'll have this early sense of not feeling well and chest pain and cough. And for a small group of patients, about 15 to 20%, and that's a high-risk cohort, will progress to this bad COVID infections that we have seen that are associated with respiratory failure and need for hospitalization and ventilation and even death.
Well, Dean Bass, that's very helpful to know. There has also been confusion, a lot of confusion based on who you hear. Originally, we were hearing that this disease is really targeting the elderly. And now we are also hearing that it is beginning to target all generations of all people. So tell us a little about who is at higher risk for contracting this disease, and why is it that it is impacting the elderly or the younger generation more than now at this point, more than usual? And also, if I had a curious question about after exposure, when is the right time for somebody to actually go in for a test? How many days before one should really think in terms of getting a test if they feel that they have contracted the disease?
Okay, lots of questions there. I'll do my best. The notion of who is at risk for this disease, basically everyone can contract COVID infection. There are, however, groups of patients that are more vulnerable to developing severe disease. And that was that early wave of patients that we saw. Those are patients that initially, and the way this disease first manifests in Asia and even here, was with these cluster outbreaks in highly vulnerable populations, those patients living in nursing homes and long-term care facilities. It's not that they're uniquely vulnerable, it's just that they are environments where the risk of spreading is high, indoors, close quarters, vulnerable patients with heart disease, lung disease, other chronic conditions. And that's how this disease became evident as a distinct new pathogen with this distinctly bad and aggressive format. Since then, however, we've realized that anybody can catch this disease. There's a debate about children and that children have not been widely tested, but they seem to be somewhat more resilient, both in terms of becoming infected, although we don't know because we haven't tested very many kids. But certainly they don't seem to get nearly as sick as those other high-risk cohorts. The other factors that predispose you, and as we've seen, not just old people with a lot of diseases die, middle-aged people and younger people that have those risk factors of heart disease, obesity, type 2 diabetes, underlying cardiovascular disease. This places anyone at risk. While it goes up with age sequentially, it's really those underlying injury under pre-existing conditions in your heart and your lungs and your vascular system that pose you the greatest risk to people of all ages. We know it started out in old people because that's who saw it and got really, really sick. The others, we weren't quite sure where they had it. And of course, we didn't really have testing early on to allow us to identify those people that had other diseases, the mild respiratory infections. We didn't have enough tests around early on. And so it was hard to distinguish these two. As we've had more widespread testing, we've been able to begin to differentiate those other respiratory-like symptoms and viral syndromes from COVID infection by virtue of now the much more widely, but still inadequately available testing to help us differentiate which populations are really, truly having this disease, how many people have it and don't have symptoms, how many people have it for how long. It's an evolving body of evidence around this, which has actually been both one of the fascinating and good things about this, if you're interested in infectious disease, but it's also been one of the frustrations in terms of managing this as a public health crisis. In terms of when you get it tested, if you think you have had an exposure, first you need to call your provider and find out whether that exposure was a real exposure, one that warrants that you go get tested. And the first thing you do is call your healthcare provider, and we can tell you whether or not a test is in your future and help you get that.
So we are really fortunate to have many experts today. So thank you, Dean Bass. And let me bring Dean Goldman into it from a public health perspective and ask her, Dean Goldman, about how is the virus today, what do we know and how the virus is spreading? And what are some of the ways in which it is getting transmitted and perhaps some of the best practices to avoid this transmission or to at least minimize the transmission?
So thank you for that question, Anush, and also thank you for this episode of George Talks Business and the opportunity to talk about this issue. The spread of the virus, I think everybody recognizes by now, is quite aggressive. One of the things about the virus that we learned fairly early on is that it has a high reproductive rate. And that's just what it sounds like. If you think about a high rate of reproduction, that sounds like you're having a lot of kids. High rate of reproduction of an infection means that one person is giving it to a lot of other people. And so, and it's a higher rate of reproduction than what we see with flu. And the fact is that it was a brand new virus coming into the world back in November, so nobody was carrying around any immunity for it. And as it turns out, even when we do develop immunity, we probably don't keep that immunity very long. So it is spreading very fast among a lot of people who have no defenses against it. How it is spread, at the beginning, we were thinking that it would be spread like a conventional respiratory virus, more or less through coughing out or sneezing droplets that then wind up on surfaces that we can pick up and move from the surface to our nose or our face and give it to ourselves that way, or winding up in something that we might touch around our environment. However, it didn't take long actually before the evidence started showing that it was actually being spread in the air through very small droplets that we call aerosols. And the difference there is when a droplet is small enough, we can actually inhale it very deeply into our lungs, whereas larger droplets tend to get caught up in our nasal passages or on our skin, don't go deep into our bodies. And that's a problem when you have something that is so harmful as a cause of pneumonia, to have the primary infection possibly happening in your lungs, which is, I think, another piece of this. So understanding that it may be in the air means that we have to control not only its presence on surfaces, clean surfaces, especially surfaces that are what we call high contact surfaces, clean our hands, be careful not to touch something and then touch our face, but also that we need to avoid creating hazards with aerosols. And they're not created just through coughing and sneezing. They're also created through talking, through singing, through shouting, a lot of the activities that we like to do when we all get together. And so that is why we have begun to have physical distancing. Some people call it social distancing. At least 6 feet between people reduces that spread, but also the wearing of masks. In normal settings, just cloth masks are good enough to stop, say if I'm wearing one, stop me from spraying aerosols into your airspace. To some extent, it will filter those out for me, but mostly those masks protect all of the rest of us. If I wear the mask, I'm protecting everybody else that I'm with. So there are many other things that we can do to try to make sure that we reduce the load of the viruses in the environment. Scott Brunotes is on this call with us. He's been very engaged with public health at George Washington and all the things that we can do with regard to our buildings and how we actually hold classrooms. And I think he can probably address that better than I can. But that's extremely important that we address also the characteristics of the indoor environment, because where have we seen some of the biggest spreading events? It's been indoors in settings like cruise ships and bars and very packed restaurants and even social events, very large social events indoors have been some of the biggest things. And then most recently, this weekend, we heard about a lot of spread through fraternity activities on other campuses across the country where they were beginning to have rush events and parties, and we see a lot of spread in that setting as well. And as you can imagine, that's been particularly of concern to us at the university.
So absolutely, Lynn, and we will talk more about how GW is preparing and all of that in just a bit. But there are certain things that we conjectured that when there were protests that were going on, that there'll be a surge because of the protests. Has that actually happened? Is there some evidence to support that? And if not, why do you think that did not happen? You did mention something that it spreads more in the indoor environment rather than the outdoor environment, but that might give us some clue as to whether it's okay to exercise outside, go running outside, and things of that kind. So maybe a little bit on that would be helpful to hear.
No, we literally had thousands of people out on the street in Washington, D.C. for the Black Lives Matter protests, and many of us were very concerned that we would see an uptick in cases. But the public health agencies in D.C. and Maryland and Virginia did not see that. And I'm pretty sure that Dr. Bass didn't see that in the hospital either. And why that would be, I think that part of it was that there people were distancing, were wearing masks. And at least the people I saw that were going out there did seem to be trying to take precautions. But then, as you note, it's possible that outdoors, we're not going to see as much of the ability of the virus to concentrate to levels where people can have a large enough dose to become infected. What we did see, many of those people did go in and get tested. We saw an upsurge in testing that we did think did have something to do with people who were out in the marches feeling that maybe they should go get a test, but most of them were negative.
Great. No, thank you, Lynn, for this. And let me bring Dean Bass one more time back on this to maybe address some of the misconceptions, perhaps from her lens, and then we'll come back and talk a little bit more with Dean Goldman as well. So there have been some conjecture, some speculation that younger people, when they do get the COVID-19, they don't necessarily get as seriously ill as some of the elderly, for example, for a variety of reasons. And I was also wondering if geography is playing a role in the spread, because in some parts of the world it is not as intense as in the US. So if you could give us some of those ideas on what may be some of the misconceptions or clarify some of these questions, that will be, I think, helpful. And perhaps also the accuracy of the COVID-19 test.
Yeah, thank you for that. Yeah, no, we really don't have any sense that geography per se is playing a role in the spread of this virus. It is spread by the means that Dean Goldman has just presented. It's an aerosolization. It's a disease that infects your lungs first and then does all these other things. The reason we are seeing more young people getting the disease now, we believe, is a function of the lack of adherence to those proven methods to keep populations safe. The things that I suspect right now in many of our communities, our older patients have learned, well, I'm not going anywhere. And if any of you that are over 60, I bet there's very few of you who've been out at the beaches or anywhere, even restaurants. That cohort has learned. Our younger people have not quite so learned. And no question, as we've seen our communities loosen their stay-at-home regulations, we have seen large gatherings of young people. We've seen, and by young I mean younger than 50, and certainly in the 15 to 30 cohort. But if you look at the hospitalizations in those southern states right now that are experiencing these surges, we are seeing high rates of hospitalization of young people as well, particularly those who are obese or those who have underlying health conditions. They can go on, although at much lower rates because of their underlying comorbidities, to the same and devastating disease that older patients died of early on in this population. So really, it's a function of, if you get exposed to this virus, if you get a good dose of it, and there is actually evidence that there is a dosing effect in terms of viral load, in terms of who is going to become sick and how, not necessarily how sick they will become, but who gets that threshold of viral dose to allow people to be infected, that you're going to get sick. It's just you're going to have a different pattern of disease based on your own personal risk factors. So I don't think the geography per se is the issue. It's really a function of how different geographic regions of our country have enforced those policies relative to containment and mitigation of this disease, social distancing, masking, large gatherings, et cetera.
So Dean Bass, I know in absence of a vaccine, as people are falling sick, I think the other part to be thinking about is treatment. The number of deaths is decreasing. Has there been progress in terms of treatment? Can you talk a little bit about that?
Yes, there has been and there hasn't been. You know, the progress we have seen has been primarily in that small cohort of patients that end up being hospitalized. And in those hospitalized patients, there are a couple of medications that have been trialed in early phase trials. I mean, the amount of data we have relative to say that, yes, this is really a wonderful new agent for this is really small, but there are several. Some antiviral agents like remdesivir is showing some benefit in preventing progression of disease in patients with severe infection from needing to go on the ventilator, for example. There's early evidence that that's also going to decrease mortality in patients who are on ventilators. That's a very small and advanced set of groups, but there is some work that this antiviral is effective. There's some anti-inflammatory drugs that are in trial, because one of the things that a seriously ill COVID patient with a COVID infection develops a massive inflammatory storm in their body, and that inflammation actually causes much damage, not only to their lungs, but to their livers and kidneys and all kinds of other really severe inflammatory changes. There's an anti-inflammatory antibody, it's a very selective antibody that's been developed that has shown some early promise, but not definitive, for diminishing the risk of death and diminishing the risk of multi-organ failure in patients who already have severe COVID infection in the hospital. And even some old drugs, again, sort of consistent with that inflammatory story. There's some old anti-inflammatory drugs known as steroids that really kind of shut down your inflammation in your body. And there's some work that even this dexamethasone is the agent in particular, that shows some promise in limiting the extent and severity of the disease. I got to say, though, that we don't have anything in development for those early COVID infections, the non-hospitalized patients. Those we just support with saying, okay, take your temperature. If you get sick, give us a call, and we'll take care of you then in the hospital. And most of those patients do just fine, and they get well and recover, and just with the usual measures. Hopefully also while staying home and keeping themselves isolated from others during that time frame.
Well, thank you, Dean Bass. And I know there has been a lot of conversation, and perhaps I can bring Dean Goldman to address this because she has done a lot of work around this in terms of the importance of testing and contact tracing, and especially in the context of opening up a campus, for example. I know you have talked about this a lot, Lynn. Could you tell us a little bit more about that importance of testing, contact tracing, and how that would apply to really minimizing the spread of the disease?
So I think that one of the problems all along has been that it's very hard to fight an invisible enemy. When you can't see it, it's hard to protect ourselves from it. And meaning that when so many of those who have the virus have no symptoms, that's a huge problem in society, and particularly on a campus where people are housed very close together, or in classrooms together. There's a lot of density of population on a campus. When the CDC took a look retrospectively at populations and the levels of immunity in those populations, they found for every case they knew about in cities across the country, there were 11 others that they did not know about on the basis of the fact that they did develop immunity. And so what we want to be able to do is minimize the extent to which there are people on our campus who are passing the virus. And also, though, we want to use testing as a way of determining what the rate of infectivity is at any one point in time, to monitor that over time and make sure things are going in the right direction and that we're able to manage the virus. Because understand, in the United States, there's no place that has achieved zero. Everywhere in the country, there is some transmission. So today, in the Washington, D.C. area, every person who has the disease on average gives it to 9/10 of a person. Now, logically, there is no such thing as 9/10 of a person, but I think, if you have, you can see how that results in a very slow decline of the numbers who are infected, but it also means that it's simmering there on the pot. It is simmering there on the pot. It has not gone away. And so we want to be able to achieve that as well on our campus. And the testing is the first piece, identify people who have the virus through doing a test that is called a PCR, where we can actually see the RNA signature of the virus from, sputum material that comes from people, and also to do with the city contact tracing, so that any one individual probably has been in close contact to a few other people, whether those are best friends, boyfriends, girlfriends, roommates, to then bring those in to make sure that they are tested, and then so forth and so on, the whole chain, to try to draw a circle around that so that there isn't continued transmission. Really critical to that for how we're doing this is that we are taking control of the testing ourselves by doing it at the university in our own laboratory, where we have a control of the supply chains, but also control of the turnaround. So right now, if you go to some of the test centers in public health across the country, because of the outbreaks across the country, it might be a week to 10 days before you get an answer. And that's not good enough to be able to control this virus. In a week to 10 days, a person infected can infect many other people, and some of them could have started infecting other people. And so you can never get in front of it unless you have more immediate test results. The other thing that would have been tempting is to use tests that are called point of care, but those have a lot of what's called false negatives. In other words, a large proportion of people who are infected show up as negative in those. So we've actually set up this lab to do the PCRs so that we can have a very sensitive way, rope in all those positives, quick turnaround, and control our supply chain, which, as you know, has been a major issue across this whole pandemic. Whether it's toilet paper in 1 week or really over time, the entire time for our hospital and Dr. Bass's people, personal protective equipment. Anything that you need in a pandemic has been hard to get. And that's been true about these laboratory supplies as well.
Well, thank you, Dean Goldman. That is actually very, inspiring confidence in what we are able to do ourselves and to set it up. Thank you for that work. Let me change the topic a little bit and talk a little bit about the impact on healthcare workers during this pandemic, because that's a big story as well in terms of understanding that better. And perhaps bring Dean Jeffries into this to ask her about what she's experiencing in terms of whether the healthcare system is right now, at least in this region, adequately able to handle the surge, if there is one, and do nurses and healthcare providers and professionals have enough ventilators and PPE equipment that we were talking about? And perhaps have hospitals been able to sufficiently provide for the safety of physicians and nurses? Because you are also, and your nurses who are graduates from our school are at the front lines as well. Dean Jeffries.
Yeah, thanks, Anuj, and thanks for doing the George Talks business. This is a great topic. But through the lens of caring for patients with COVID, particularly at the beginning, and now with increased spread, cases surging across Florida, Texas, and Arizona, PPE was, and it's still a problem, particularly in certain geographic areas. From the beginning, the equipment was rationed, a lot of it was unacceptable, and as we know, many healthcare providers and workers became ill, and some passed away. Overall, I believe the healthcare organizations in the states, they were doing the best they could when we didn't have the equipment we needed. They were trying to work together across states, across institutions. And I do know at times there were orders that were made from hospital executives thinking the tests were on their way or the equipment was on the way, to find out there were delays or cancellations of the orders. So that went on and on, lots of frustration. Also at the outset, there was a belief that ventilators were, we didn't have enough ventilators, so there was a big shortage, so more ventilators were made, then they were distributed to those states hardest hit. I think of New York being the epicenter there. But then based on the unfolding science and the discovery, we had a lot of ventilators and states were sharing ventilators, and less ventilators are being used because now we're trying to keep patients off of ventilators and other interventions being used. I know now in talking, a lot of the intervention is that early proning, laying the patients on their stomachs, on their front. So it's a simple intervention. It doesn't require ventilators, but and then, of course, with other new discoveries, Dr. Bass mentioned the discovery of medications and interventions. Hopefully, those will help, but supply will be a demand, as we see. But with time, hopefully, we'll get more PPE, the medical equipment, the interventions. They'll all be where we need to see them today.
Well, thank you. And Dean Jeffries, we are all staying at home while the nurses and the frontline workers have to be going into work every day and taking care of things. What are some of the ways that the communities can support the nurses and healthcare professionals that we are not doing perhaps as a community?
How can the community support nurses?
Yes.
Well, I've heard many nurses' stories on the front line. They were going to work, they were putting their families in harm's way, but many, they're heroes. You see the signs. And how the community's been helping nurses as well as other healthcare providers. You've seen signs in the yard, you've seen billboards, free lunches have been given and provided at the healthcare organizations. And I know healthcare providers have appreciated that. more than you know. In fact, I've been interviewing some frontline nurses we're developing modules on building resilience during this time. It's not just for nursing, but other healthcare providers. And nurses have stated how the community has helped them, because at times they were depressed because they couldn't go home and be around their families, or they had to quarantine. Some did get COVID and had to quarantine away from their families. But anyway, that's one way community can help. And in addition, I'll just say this. Recently, as Dean of Nursing, as we're through this disruption, people were saying, well, how can we help? What do you need? What do you need, Pam, at the School of Nursing? Or how can we help your students and nurses at this time? And I said, through scholarships, being the Dean of Nursing. We need more nurses on the front line. We need more nurses in the workforce. In 5 years, 1/3 are at the retirement age. So we need to produce that workforce, and we're 4 million in number. So we're the biggest healthcare provider at the front line.
Well, I couldn't concur more with that, Pam. And I think you mentioned a little bit there about the nurses themselves with all this work getting a little depressed. And of course, mental health issues have been at the forefront even before COVID-19. And certainly they are impacting a lot of folks who have nothing to do with being healthcare provider. But I can only imagine what it must be to be a healthcare provider seeing all this every day. And so I want to hear a little bit about some from that angle on what kind of mental health issues are arising and what should be done about this, not just for the healthcare providers, but also perhaps for the community overall.
So thanks, Anuj. Mental health care and services couldn't be more important during this time. We're on month 5 of COVID, and speaking of healthcare workers on the front line, day in and day out, 12-hour shifts, being quarantined. Many didn't go home to their families because they were afraid to spread the virus. Many lived, they slept and they got up and go to work. Just dealing with the uncertainty of the virus, that's very stressful. We're all experiencing that. You don't even have to be a healthcare provider to feel the stress. When I have my faculty town hall meetings with faculty, staff, and students, you can feel we all want answers to questions that we don't have yet because of the uncertainty. So that causes stress. So in the front line, and again, I interviewed a lot of frontline nurses for this nurse resilient modules that we're developing. And many were stressed, but that's their calling. They wanted to be there, they make a difference. And many nurses I heard from, they felt they were doing what was needed. They were providing the care, they were dealing with human responses. When families couldn't even be with the patients, they had to be there. They were the families of the patients, they were the care providers, they were all of that, and trying to make connections. But it wears on you. There are days where nurses have to take mental health days. It's just overwhelming, it's too much. It's not just nurses, it's all of our healthcare providers. And what we're seeing now a little bit it's some post-traumatic stress, where people are, we're month 5, where people want to take a furlough. They want to take days off. They want to take weeks off, and we must grant that. But there's mental health services out there. I know there's 24/7 virtual health services. It's not only for our nurses on the front line and healthcare providers, it's for our students. It's for our faculty, staff. GW is doing a great job. I know through Colonial Health for students, there's a 24/7 virtual online health counselor. There's also self-help. There's toolkits. And support. When I even talk to nurses on the front line, they're there for each other. So the healthcare providers are providing that support, and healthcare teams. Again, it's not just nurses. So overall, it's due to the uncertainty, stress is very, very prevalent, but I think we're doing the best we can. And overall, it's not, nurses don't want to leave the profession. In fact, they want to be more helpful, and what can we do? And we're seeing the nursing enrollment in our program. It's good. People are still saying, I want to come into the profession. I want to help. It's a service-giving profession.
That's great, Pam. So thank you very much. And I want to turn a little bit to a very important discussion as well about the return to campus that we have been talking about, or a lot of questions have come in. Let me start with Dean Goldman to tell us a little bit about how the government officials are determining when to reopen and what are the different phases, and how do these tie in with how the university adjusts to the various academic and operational planning that it has to go through to be able to welcome students back to campus? Dean Goldman.
Well, thank you for that question. But to actually completely describe what all the different governments across the United States are doing and how each state and the federal government as well are making determinations would almost be the equivalent of a doctoral dissertation. But I'm going to give you kind of the brief version of that. There's a basic approach that the White House Task Force on Coronavirus came up with, which calls for reopening in a set of phases, all the way from a first phase where people are continuing to be at home, but a few businesses are opening, all the way to a phase where we have a vaccine and can more or less return to normal, to, by the way, in their framework, a last phase where we're then preparing for the next big one, which should really be on everybody's agenda, because we've had a number of warning signs for this, but we really weren't as prepared as we should have been. Where we are in Washington, D.C., they've taken that model and somewhat revised it. They've actually elaborated on it, made it a little more complex, and come up with some very specific metrics that the District of Columbia is using to kind of help move us forward. And I think they're very sensible metrics, by the way. One of them has to do with the actual rate of reproduction of the virus, and that it needs to be below 1. So every person who's infected doesn't quite give it to one other person, but to less than one other person. And in that way, the infection just keeps declining. And then they set up kind of arbitrary, but I think nonetheless sensible guidelines about having those declines go for a number of days before they move to the next phase. They've also said we want to have plenty of capacity in the hospitals to be ready, because when this virus breaks loose, it can do it very quickly, and you may start to notice an uptick, but you may end up like we've seen in Texas right now, and in parts of Florida and parts of actually Southern California, the hospitals being bombarded with cases. And so DC is keeping the hospital occupancy down below a certain level as a condition to being able to move from one phase to the next, just so that we're ready in case at that next stage we've stepped over the line and we've gone too far. The third thing that they've been very concerned about is making sure that there's enough testing. So they have actual goals of proportion of people who are tested and test positive. The idea here is that if there's enough testing, the rates of test positive will go down and down and down. When we have hardly any testing, and that was the way it was at the beginning, almost everybody getting tested was pretty sick, and a lot of them were infected. When you have more availability of testing, you see a lower rate of positivity, and that's a good sign. And so that's one of their metrics. And last but not least, they really are concerned that they have enough people doing contact tracing. And they measure that by looking at their ability to do a complete job of contact tracing within 24 hours. And right now they're at a point where like 98% of the time they can do that, which is pretty amazing. But of course, if there's a major recurrence, they'll start falling behind that. But their goal is 90%. And they are trying very much to increase the numbers of people who are doing this contact tracing. I've looked at some other states as well, and they're all somewhat different, because one thing the federal government did not do, it did not set these specific guidelines. It did not set bright lines that you're okay if you're here, you're not okay if you're there. And so as the states have been doing it, they're doing it differently. And in some ways, that's concerning, because some of the states have been pretty relaxed about it. They've said, oh, we're going to go right from 1 to 4 and open the bars. And we've seen the results of that in some of the states. But many of the states are developing good systems. They're just different systems. And I think that, and that's where the dissertation part comes in, because there is no textbook of COVID-19. There's no handbook we can pull off the shelf to say, this is the way we must do this. And so I think we will learn from the fact that there are these different approaches being taken, which are working, which are not working. But I would feel more comfortable in any state where they're making the effort to use science and public health as a basis, and not just on the basis of what's more popular. Because I mean, of course, a lot of people want to feel that it's normal again. We all do, but that's not necessarily, it's certainly not a science-based way of approaching this.
Right. No, and I must admit, in absence of a textbook, we are fortunate that we have you and others on the panel here who are actually guiding us through this process. And let me bring, from that perspective, Scott Bernutz on into this conversation as well. Scott, you have had a lot of experience planning for safety and health, community, university setting. Tell us a little bit about the university plan for reopening campus.
Yeah, sure. We started planning, and even prior to the virus making it to the United States, right? And one of the benefits of being at GW is the experts that we have within the university. My colleagues that are on this panel alone, they represent schools and faculty and students that have been able to assist us throughout this process. And so we were starting the planning initiative. We were actually responding as the virus, made it to the United States, and we were taking actions nationally. But then we started planning for the fall reopening, right after we went through the spring, and then DC came out with their stages and their guidelines based on the national guidelines and the requirement for us to have a fall reopen plan. And so, what we're calling the reopen plan is it's if you're thinking about kind of maps and directions, it's our map, right? It's guidelines. It kind of paints a broad picture of where we're going and how we're going to get there. We've also created something that we're calling the Operational Playbook, and these would be the turn-by-turn directions. And so we've had a number of hundreds of experts representing different areas, from academics to operations, finance, communications, health, and they've all been playing a part in this big plan that we've provided the District of Columbia. And then we were creating the Operational Playbook, and we had a number of individuals, about 129, that were not part of the original planning process to evaluate it. We used a military term called red teaming, where they were there to kind of really look at it from different perspectives, and we had to defend it much like you would defend a dissertation. And so we asked 50 questions in this huge document of information, and they were providing a number of different responses so that they were giving us different things that we needed to address before we make this go live. This actual document, the playbook, will not be a physical document that you would print or read like that. We're going to actually put it on the George Washington University website, and we're going to publish it as sections of it are ready, and it's going to be a living document. The one thing that we know about the COVID-19 crisis is that things will change, right? And they will change rapidly. So we will publish this in kind of a web format that individuals will be able to go and reference throughout it. It will be sectioned off for specific audiences, faculty, staff, students, as well as specific circumstances like campus activities or events. And therefore, the people will be able to go and find very specifically the information that they're looking for.
Thank you, Scott. And I know I have gone through some of the draft of that plan myself, and I think that will be very useful for people to know. But a lot of folks who are listening to us today are not familiar with that operational playbook. So let me take some of their very specific questions and see if you can, and as we are working through them, and see if you are able to shed some light on it. For example, some concern is in this is how are we going to be able to ensure social distancing? Are we going to require masks for everybody to wear? How are we going to enforce something like that? And with some earlier conversation, for example, when we know about how this disease is spreading or transmitting, are we doing something about the ventilation in some of our buildings, et cetera, to ensure safety of our students and faculty and staff? And if you could share some more specific things about the operational plan that you can share with our audience today, that will be very useful, I think.
All right, so you're gonna have to keep me on track because there's a lot of questions. But
More are
let's
coming.
start with.
More are coming, Scott. There's a whole list of
I
questions
know.
I have here for you.
I can't wait for the playbook to be published. But let's kind of start with some basic parameters. One thing that we are starting with every individual is we are creating something called the commitment, right? And that's a passive pledge that each individual will need to make to understand what their behaviors and expectations are as they return to campus. There's going to be sections of that of what I need to do to take care of myself, what I need to do to take care of my colleagues, and what I need to do to take care of my community. It is so important, and you've heard the other or my colleagues talk about these types of behaviors that will help us defend ourselves against the virus that we want people to take. And what I will stress to those watching is if you're not willing to commit to these types of behaviors, then I would have you seriously rethink about coming back, because we need you to commit to these types of behaviors, right? Now, when we get past the commitment, then what we're going to do is obviously we're going to do specific types of trainings to talk about these behaviors or these different circumstances that we are expecting from our students, faculty, and staff, right? There will be a number of communications throughout this process, reinforcing what we will be expecting. Then you're going to see a lot of signage when you come back to campus. Some of this is required from DC Department of Health or the different jurisdictions that we have campuses. And some of this, a lot of people are very familiar with, right? They're constant reminders. 2 people only on an elevator, 6 feet of social distancing in these different spots, where to stand, where to sit, or in some circumstances, where not to stand or where not to sit, right? So it's just visual reminders to a lot of these social distancing. Then what we've also done is we've actually physically modified some of our spaces, right, to ensure social distancing. Sometimes that is by putting labels over chairs to say you're not allowed to sit here. Sometimes we're physically moving furniture around to have social distancing, or we're going to have to close certain areas that aren't really capable of allowing social distancing. Then we're really focused on capacity limits, right? So you'll see within the different jurisdictional plans about the need for continue to keep capacity low through teleworking, or limits on the number of people for social gatherings or gatherings in general, right? So we're looking at physical spaces and understanding within the social distancing requirements that, a room that maybe would have fit 100 people during normal times will now only fit 30 or 40. And so we're having to make those types of adjustments. Then I will, kind of to touch on some of the enforcement questions, because we're getting a lot of questions about enforcement, right? So there is a health and well-being policy that will be issued, right? And this will talk very specifically about those behaviors that we're expecting the faculty, staff, and students to have during their time back on campus. And then also some of the repercussions or the actions that could be taken if someone just continues to not follow the behaviors that we're wanting to follow within the university, such as wearing masks, as well as the requirements within the jurisdictions that we have campuses in. So yes, we are going to require masks on campus, again, because we know that is one of the best defenses against the spread. And so to answer, I believe, some of your other questions, regarding ventilation, that's another one that we get a lot of questions about. With ventilations, the big key is to make sure that our actual HVAC air conditioning systems are working properly. So one of the benefits of over this summer and not having a lot of people on campus, it's allowed us to do a lot of preventive maintenance on our different building infrastructures that we've had around campus. So we're making sure that the systems are working properly. That's the first step. But then we're following CDC guidance. We're flushing the air systems. We're flushing the water systems. We're actually adjusting the set points on the HVAC systems. And we're maximizing that kind of the fresh air that we're able to circulate through the system. But we're also monitoring because, like, it can have a cause and effect, right? We don't want to maximize the fresh air intake, but then create other problems, with mold or other things. And so we're going to be monitoring those systems throughout the year, because right now it's very hot outside, and later in the fall it's going to be very cold, so things will change rapidly. Kind of getting back to the enforcement piece, again, it starts with individual accountability, right? And those individual behaviors. And that's why it's so important that, all of our faculty, staff, and students, look at the commitment and be willing to because it's not going to be like a normal semester, right? And then there's going to be kind of this community accountability that, with our colleagues, if we see our colleague not really following the guidelines, we're going to want to reach out to them and say, hey, I really I feel uncomfortable that you're not wearing your mask. Can you put on your mask? Sometimes if someone's making you feel uncomfortable or they're getting into your space, you can back up. But we want to have that kind of community accountability. And then there's going to be individuals that are in areas of authority, right? So myself as a supervisor, right? If I see one of my employees constantly not following or practicing these good behaviors, I'm going to have to take an action and go through based on what's outlined within the policy about correcting that behavior.
Yeah. Thank you. That was very helpful, Scott. I know it must have helped a lot of people who are listening in about various questions that they had submitted. Let me ask you one other question, and I know we have so many that we can go on and on, but let me at least ask one more question. As you pointed out, and as others have said, the one certain thing about COVID-19 seems to be that it's uncertain on how it will evolve and what's going to happen. So there are a lot of questions from students and from their parents about, in case they end up actually getting infected, what are the plans from the university's perspective to help self-isolate them, quarantine them, and care for a student who has been tested positive, for example?
Yeah, so the university is going to require anyone who tests positive, and that they can test positive through the systems that Dean Goldman and others are creating, or it could be from their primary care physician or a hospital visit, right? If they test positive, they're going to have to isolate, right? And so if they're an on-campus residential student, we will have a facility set aside for the residential students to be able to isolate, and there will be a process to be able to care for those students as they're isolating on campus. Now, if you're a student who's living off campus or with family members, right, you're going to need to plan ahead to what would be that process of isolating off campus. The same is true for quarantine as well. So if you're ordered to quarantine because you meet the definition, the current medical definition for exposure, on campus there will be the capability of the quarantine. If you live off campus, we're going to be asking you to quarantine off campus. We're creating what we're calling the campus COVID support team. This is a team that's going to play a very important role within this process, because when an individual tests positive, this is the team that's going to be working with the local health departments, because the local health departments are responsible for the contact tracing, right? So they're going to be helping the local health departments with providing information, but they're also going to be supporting our students, faculty, and staff, right? There's a high level of care that we want to provide them as well. And so they will guide them through the process, what different actions that they would need to take.
Thank you, Scott. That was very helpful again. And I know we are going to be running short of time, but I do want to at least bring Dean Goldman back to answer one other question which has been on people's minds in terms of the availability of the testing and the frequency of the testing. And will we have enough tests for everybody? Will all the students, staff, and faculty be able to get one if they needed one? And what are our plans in terms of the frequency of the testing that you started talking about earlier?
So these are plans that we're still in the process of making, but there will be enough for everyone. And in fact, we are going to be requiring that everybody be tested with some frequency, although they will need to consent in as part of their consent for many other things that they consented for being on campus. But initially, what we're hoping to do is that first and this is very aspirational, but I think we may be doing it, and that is that our undergraduate students, before they even come to campus, to do a test at home. And so that will give us a sense of the prevalence of the virus in that population. We know it's very low in DC and Maryland and Virginia, but our students are coming from all over the country and areas that have more virus. The second thing will be that everybody, faculty, staff, and students on arrival will be tested for the virus, and then will be tested 1 week later. And we hope through that process to be able to identify and isolate anybody who would have been bringing the virus onto campus, but also if there's an initial wave of spread because of everyone coming together to capture that. And then from that point on, we're testing everybody periodically. We're still, though, working on, whether do we test everyone with the same frequency or take a higher risk group and test them more often. That's something under discussion this week. And so even though we have the lab, we have the equipment, we're hiring the people, we're still putting the finishing touches on the protocol. And frankly, we're still learning from the experience in other places about what's likely to work the best. So I mentioned before about the illnesses that are popping up on campuses just this week. When students are returning and having fraternity parties. So we're looking very carefully at the dynamics around that, because that is hearkening to there may be this higher risk group that we may need to address more frequently. One of the challenges to all of this, by the way, is the return of information to everybody. And a question I get all the time, well, one, I get the question, do I have to pay for the test? And the answer is no, they won't have to pay for it. I get that question all the time. Second, how long will it be before I get the results? And we're aiming toward a 24-hour turnaround, electronic return of results that's nonetheless confidential for the individual. And then who gets the results? Well, DC Health gets them. If they're positive results, Employee Health and the Colonial Health Center get it. Most importantly, if there's a positive result, this campus COVID support team will immediately be in there to help to get people into isolation, as well as if they have roommates to then quarantine, the roommates make sure that they are further investigated, even while DC Health is doing the formal contact tracing that they will do. So there's a lot of moving parts in the thing, as you can well imagine, different systems. On top of all that, we're going to ask everybody to monitor their symptoms every day and to get in touch if they're having patterns of symptoms that may be indicative of COVID-19. And then do just what Dr. Bass said, if they have those symptoms, in terms of reaching out to healthcare.
I want to thank the panelists and all of you who joined us today in what has certainly been an enlightening conversation for me. Our nurses and our doctors at the front lines are really working hard, and I know we all share the respect, the regard, the affection for them, and they have been out there at the front line saving lives. So thank you very much for all the work that you are all doing for the community overall at the front lines of the pandemic. By the way, we are going to continue with our George Talks Business series, and the fall lineup, which is turning out to be a great one, will be announced soon. So until then, please stay safe, please stay healthy, and please stay connected. Have a great summer and see you soon. Thank you for joining us today.